This is a picture of a plasticized dead body by Professor Higgins. And this is the picture taken from notebook of Leonardo da Vinci, the artist, who was famous for its medical illustrations. Now you see the similarity. This plasticization, Professor Higgins, who I met in Singapore, I told you previously. But the interesting fact is this, a similar picture. The uterus is cut open and showing the picture of a baby. And this is the placenta here. And see, this is the baby. This is a plasticized dead body that has been cut open. And the baby is being shown. With this little bit of historical introduction I'm telling you, because I admire these people. And history, actually, I'm very interested. You have to know the history of your own country, your own family. I told you earlier. And also you have to know the history of medical science. Now, shape of the uterus. Shape of the uterus is hollow, pear-shaped, with thick muscular walls. Location between the bladder and the rectum, within the broad ligament, lower end of the forms an approximate right angle with the vagina, an angle of anteversion. Now, size of the uterus in young nulliparous woman, it measures 8 centimeters long, 5 centimeters wide, and 2 centimeters thick. Now, this is an organ. The lung you cannot get like this. Pathological lung, it can have solid tumors, but it cannot expand. But the uterus with its appendages, ovaries, it can grow into 12 kgs, 13 kgs. And lastly, I operated few months back on ovarian cyst, 12 kgs. So you can see what I want to stress, a small normal size uterus, the patient is having excruciating pain and dysmenorrhea with a small uterus. But with a large uterus, fibroid of this size does not bleed so much. And different sizes of uterus is such that it really, I wonder at times after operating on few hundred women in this my career. Now the parts of relation, the fundus, convex, related to the coils of small intestine directly anteriorly and superiorly. Body, vesical surface lies on the superior surface of the bladder and covered with peritoneum, which is reflected onto the bladder, forming the vesical pouch. Intestinal surface related to the sigmoid colon, the coils of small intestine and covered with peritoneum. Lateral margins receive uterine tubes, uterine vessels by the side and related to broad ligament, mesometrium, round ligament and ligament of ovary. The cavity of the body is triangular in cardinal section, but merely a cleft in sagittal section. You have a specimen in our lab. This sagittal section, you will see it's a small cleft. Now, parts and relation. Now, the isthmus, constricted part of the uterus, 1 centimeter long in length and cavity called internal os. Cervix extends downwards and backwards from the isthmus to pierce the anterior wall of the vagina, divided into supravaginal and vaginal parts. Supravaginal part anteriorly the bladder, posteriorly the coils of the small intestine. Now laterally uterine artery and ureter embedded in the parametrium. The vaginal part protrudes into the vagina, forms vaginal fornix. The cavity of the cervix, the cervical canal, is spindle-shaped and communicates with the cavity of the body through the internal os and with the vagina through the external os. Now this is the internal os and this is the external os. Anteverted, retroverted. Now you have to know these positions because in gynecological practice, in obstetrical practice, you have to know the angulation, especially a lady comes to you with amenorrhea. Now she wants to abort the child or the fetus according to the, but you have to, when you do an MTP, you have to know by per vaginal examination, is it anteverted or retroverted. Accordingly, when you introduce the different sizes of uterine sounds is the instrument. One is like this with a metal, these are all metals. These are different sizes. It's round shaped and you dilate with that. With the first uterine sound is the shape like this. You hold the sound and put it like this. If it is anteverted, you will see, you can feel it. You can feel it that it's passed through the internal os. If it is very angulated, then don't put pressure. Don't put pressure, otherwise you will perforate. Now you slowly, you just spasm, that's spasm. You have given antispasmodics. Now you slowly, it will go number 1, number 2, number 3. Gradually, your diameter increases. Now, and see, if you put a sound like this, you can feel the fundus, you can feel it. You have to be cautious, you just put it like this and it just touches, some obstruction is there. And then gradually you dilate, then you put your suction cannula and you terminate. And then you curate, you use the ovum forceps, you evacuate it and see if you are doing it the first time, then you have a kidney tray and also the transparent cannulas. Previously it was metal when plastic was not discovered. So that cannula, you can see the things are going in. If it is a 6-week pregnancy, then you can see the sac and fetal material going through. So you will have an idea that the size of the your fetus, if it is a 12 weeks pregnancy, then there will be placenta, small placenta, and Accordingly, you handle the case. Now, this is one thing. Now peritoneum, from middle 1/3 of the rectum, peritoneum reflected on the posterior surface of the upper part of the vagina, recto-uterine pouch of Douglas, continues over the intestinal surface of the uterus body and passes around the fundus, continues down over the vesical surface of the body at the level of the fornix, anterior portion of the vagina, and peritoneum reflected onto the posterior surface of the bladder. The peritoneal relation. Blood supply of the uterus, the uterine artery, branch of the internal iliac artery, the ovarian artery, partly branch of the aorta arising from L1 level. Now venous plexus, venous drainage. The venous plexus drains through the uterine, ovarian and vaginal veins into the internal iliac veins. Now lymphatic drainage, fundus into para-aortic nodes, body and cervix into internal and external iliac nodes. Note a few lymph vessels also drain into the superficial inguinal nodes. So, if it is draining from the uterus into the superficial inguinal nodes, then you have to do a vaginal examination and also speculum examination. The duck bill, you have seen quack, 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 ducks. So that is known as duck bill speculum. Now, if this is a mechanism that you press this, it will open up. Speculum will open up like this. Like this. You press, it will open. It's a simple but very useful instrument. When I was doing my internship, actually, Professor Ghosh, he was a fantastic person, and also at that time, in 70s, he was one of the best gynecological professors in West India. To hona hai, but West Bengal, I'm telling you. I learned how to handle gynecology and obstetrics from him. 1 month or something, 6 weeks or something, or 3 months. No, 3 months of gynecology and obstetrics. Now, in that period, and today I am recalling him. Every day I recall him because he taught me that you must examination a woman with a lady assistant and see the cervix, the vagina, is what pathology is there. Most of the young practitioners, I'm talking that they don't look into the vagina and this thing in their routine practice. So, a patient with menorrhagia, now why are we using? The lady might have a cervical polyp of this small, like the size of a small marble. Now, the patient is bleeding. Now, I have a cycle of 15 days, 16 days, 20 days, whatever it is. Then you ask for post-coital bleeding. After intercourse, do you bleed? Now, only if you visualize that if there is a small polyp, you advise her that you have to take you make a small operation. It's an outdoor procedure. Operation means take that tissue and send it for histopathological examination. So, small, but a big fibroid must not have abnormal uterine bleeding as such. Now, the significance of internal os, external os and speculum examination, I think you should carry it till 70 years of my age. Every day at least 6 speculums are boiled and sterilized. I use it for every vaginal examination. Now, nerve supply, uterovaginal portion of the inferior hypogastric plexus, sympathetic supply from T12 and lumbar 1, parasympathetic supply from sacral 1, sacral 4. Critical notes, uterine examination by bimanual palpation and prolapse of the uterus. So bimanual means you wear gloves and then you put your 2 fingers in the vagina and in the lower abdomen. You just see, you can feel this thing. Even if it is a come for any MTP also, you have to do a vaginal examination to me. You have to do a bimanual palpation to gauge. Then you order for an ultrasound for pregnancy profile. Now you will get the true picture more or less if the sonologist is not in a hurry. Sometimes a phone call, Durgapur se Ilam Bazar, jachi. So these things are going on. I think being my students, you won't be doing this. Now, the prolapse, the supports of the uterus. This is an important long question. Supports of the uterus. And supports of the uterus, normal position of the uterus, anteverted extends forward and upward from upper end of the vagina at approximate right angle, anteflexed, body bent downwards at its junction with the isthmus. This position is generally maintained by muscles, fibromuscular structures, facial condensation, ligaments and possibly peritoneal folds. These are the supports of the uterus. Now you go detail. Now see the angle of anteversion. Every book is having this. Every book is having this. Now you see 90 degrees angle of introversion. These are the 2 position of anteversion. Now angle of anteflexion, position of anteflexion, this is 170 degrees. Now important supports, the levator ani muscles, anterior fibers, pubovaginalis from a sling and supports the vagina, indirectly supports the uterus and fibers inserted into the perineal body. Note, you please see perineal body. It's a structure, I'll show you the illustration. That it is inserted in the perineal, it tends to sink into the vestibule along with the uterus. Now note, if the levator ani is torn during childbirth, support of the vagina is lost, it tends to sink into the vestibule along with uterus prolapse. Now, perineal body is situated between vagina and rectum and stabilized by numerous muscles. Examples: superficial transverse perineum and external anal sphincter. Acts as an anchor for levator ani and maintain integrity of the pelvic floor. Urogenital diaphragm. It can be a 4 marks question. What is the urogenital diaphragm? It might be the 4. Now, some fibers from the attached to the vagina and help support both vagina and uterus. Now, important supports: ligaments. These are condensation of pelvic fascia on upper surface of the levator ani muscle attached to the cervix and vagina, supports uterus and keeps cervix in proper position. Transverse cervical ligament, cardinal ligament, connect lateral aspects of the cervix and upper vagina to lateral pelvic wall. Pubocervical ligament connects cervix to posterior surface of pubis. Sacrocervical ligament connects cervix and upper end of the vagina to lower end of the sacrum. Forms 2 ridges, one on either side of the recto-uterine pouch and helps maintain uterine axis. Round ligament of the uterus, remnant of lower half of the gubernaculum, connects lateral angle of the uterus to labia majora via the inguinal canal. Now, uterine axis, anteverted position of uterus prevents it from sagging down the vagina. This axis is maintained by the round ligament of the uterus and sacrocervical ligament. The following are the possible supports: broad ligament, uterovesical fold of peritoneum, and recto-uterine fold of peritoneum. Now, this is a very good illustration. Now, please, when you go to the dissection hall, see at least once, view it in the dead body and see it and all the organs, all the position of the uterus and the position of the ovary. Okay? Now, see, this is the sacrum, this is rectum, cervix, this is urinary bladder. You draw uterosacral ligament, this, the transverse cervical ligament, the cervix of the uterus, cervical ligament. This is the pubis, urinary bladder, pubocervical ligament. This is symphysis pubis. Now you see the symphysis pubis here, uterosacral, sacral 1, 2, S3 and S4, S3, not S4, and sacrum, the round ligament here, through the external opening of the inguinal canal, it will go to up to the labia. Now, pubocervical ligament. Clinical notes: tear of the perineum may cause a prolapse of the uterus, also due to hard labor or weakness in any part of the support. Now, this is the picture illustration. The uterus is cut open. This is cut open, myometrium. This is the ovary. This is the uterine tubes, endometrial cavity. This is done a window dissection to show you the internal part. This is the normal. Now you see the sagittal section. It is positioned like this. There is a specimen prepared by Professor Sapon Bhattacharya. The sagittal section, anatomical specimen. You see this uterus. This is a laparoscopic view of the uterus, what you see from the laparoscope. Now you can see the uterus. This is the ovaries here. This is the round ligament. Now this is another illustration. You see the axis of the cervix. This is the bladder, the angle of anteversion, axis of the vagina, axis of the uterine body. Now again an illustration of the uterine tube, laparoscopic view, the ectouterine pouch, uterus, see the fallopian tube. This is the fallopian tube or uterine tube. This is the broad ligament, this round ligament, external iliac artery, external iliac artery, with the rectum. Now catheter balloon in the bladder. This is the balloon, and uterus is here, uterine tube. Now ostium of the uterine tube, this is the ostium, fundus, ostium of the right uterine tube. Now this is the old picture from Grant's anatomy. I just, for a lovely illustration, very specific and easy to draw. Okay. Now this is another illustration from Netta. This you see, this is a very good. Now the ovary, and the tube, fallopian tube, fundus, anastomosis, ovarian and uterine vessels. Yeah. This is uterine. The corkscrew like. And see the relation, the ureter and uterine artery and uterine vein. Now you have to be careful in during hysterectomy operation. You don't clamp the ureter. Okay. Now this is another section with the supports of the uterus. The normal uterus is shape is this, fundus of the uterus, uterine cavity, and ovary, the body of the uterus, cervix, vagina, external os. Now double uterus and double vagina, uterus didelphys. Uterus didelphys is you will find in your practice. This you have to note and see. Okay. Now, actually, usually what happens? Now, everywhere, especially remote areas, but government is trying to give help in some way by doing a 3 ultrasounds. There will be 2 ultrasounds at the first trimester or just when she gets pregnant. And second, an anomaly scan 18 to 22 weeks. And third in the third trimester. Now this is the double vagina. Double uterus with a single vagina. Bicornuate uterus. You will come across USG reports. Bicornuate uterus, because the female who 2 pregnancies are lost, but she has not done an ultrasound. You order for an ultrasound, and also order for a hysterosalpingography, HSG. Okay, hysterosalpingography. Now, bicornuate uterus with rudimentary horn. The bicornuate, but this is rudimentary. Septate uterus. See, that's the septa. So, pregnancy may occur in one cavity. This can be. Now, with endoscopy, the septum can be, if she is going for a repeated abortion, then you have to be very judgmental and you can remove the septum by surgery. Now, unicoordinate uterus. Unicoordinate uterus. Unicoordinate uterus is a very rare condition, but unicoordinate uterus even can give a child. It won't be aborted. I will show you a patient I encountered, and she had an unicoordinate uterus. Now this is the arterial supply. This is the laparoscopic view. See, the obturator artery is here, obturator nerve here, external iliac vein, external iliac artery. This is again cut picture, histology, MRI. Now, location of uterine fallopian tubes. Upper free border of the broad ligament, mesosalpinx. Extent of uterine tube, 10 centimeters long, runs laterally from uterus to the uterine end of the ovary, passes upwards on meso-ovarian border, arches over the tubal end, terminates on free border of the medial surface of the ovary, not joined by two ovary over released into the peritoneal cavity. Now, parts of the uterine tube: infundibulum, ampulla, isthmus, intramural. Now, lateral expand part with abdomen ostium, surrounding by finger-like fimbriae. It is like this, like a fimbriae, like this. The fimbriae, you see the your specimen, and inner surface lined by ciliated columnar epithelium. The fallopian tube is lined by, the fimbriae is lined by ciliated columnar epithelium, because the ovum is released by the ovary. Then Maharani is released. Now she is given a red carpet. Think of the fallopian tube. But before that, the chhatri and all this, and hawa dete hai. So, with the ciliated columnar epithelium, the ovum goes into the fallopian tube and then goes into your intramural part of the uterus and then gets lodged in the uterine cavity. This is the process how it goes. Now, it can be such that it does not progress such. So, but she is having amenorrhea and she comes with an acute excruciating pain. You go for a urine test, but she is having pain. That means you have to suspect that it is a ectopic pregnancy that might be ruptured. It's a very acute emergency. But if she is not complaining of such pain or something like that, but you do a routine ultrasound, you get ectopic pregnancy. Nowadays, there's a trend amongst us, I would say. Us means the medical plan, that without ultrasound, we go for an MTP. That was our previous day, where there was no ultrasound. But in today's modern time, everywhere there is patent photo kara hoy, you will get NV place. At least 40 or 50 ultrasound machines are there. And medical college and also your Shian hospital. Now, there won't be any failure of diagnosis. Now, blood supply of the fallopian tube, medial 2/3 of the uterine artery, branch of the internal iliac. Lateral 1/3 ovarian artery from the abdominal aorta. Now, venous drainage of the uterine tube, campaniform plexus of ovary and uterine veins. Lymphatic drainage, most of the drain into the lateral aortic and pre-aortic Pre-aortic nodes, some round isthmus, follows round ligament of the uterus into superficial inguinal lymph nodes. Now, nerve supply T10 L1 via inferior hypoglossal plexus, parasympathetic mainly from pelvic splanchnic nerves S2 S4 via inferior hypogastric plexus. Now, tubal pregnancy common ectopic pregnancy, sterility caused by blockage of the tube due to inflammation, female sterilization by tubectomy, ligated and excised. Now, size and shape of the ovary is diamond shape, dimension 3 to 1, 3 into 2 into 1 centimeters. Now, it's located in the ovarian fossa. Now, lateral wall of the pelvis behind the broad ligament attached to the back of the broad ligament by meso-ovarium. In nulliparous women, its long axis is vertical. In multiparous women, upper pole laterally and lower pole medially. Parts of the ovary, it has lateral and medial surfaces, and upper tubal and lower uterine poles, anterior meso-ovarian and posterior free borders. Relations of the ovary, anteriorly obliterated umbilical artery, posteriorly ureter, internal iliac artery, the obturator nerve crosses floor of the ovarian fossa. Posterolaterally, fibulae of the infundibulum of the fallopian tube. Now, suspensory ligament, fixation of the ovary. The suspensory ligament, peritoneal fold running from its upper extremity to the iliac vessel between attachment of the meso-ovarian and lateral wall of the pelvis. Carries ovarian vessels, nerves and lymphatic. Round ligament of the ovary from upper end to the lateral wall of the uterus, medial margin of the ovary. Remains of the upper part of the gubernaculum, round ligament of uterus remains the lower part. Meso-ovarium joins the anterior border to the posterior side of the broad ligament, transit vessels and nerves. Now, blood supply of the ovary, branch of the aorta at L1 level descends in the suspensory ligament of the broad ligament and sends branches to the ovary and uterine tubes. Anastomose with uterine artery, especially right side into ovarian vein, drains into right side into inferior vena cava, left side into left renal vein. Now, those who are fighting for honors or gold medal, even you take note of this part when you're giving a viva, or the person who want to score around 80, 90, whatever honors, you please note. Now, nerve supply of the ovary, ovarian plexus, derived from the renal, aortic and hypogastric plexus accompanying the ovarian artery, contains sympathetic nerve T1 to 11, parasympathetic nerve S2, 3, 4. Thus, pain is referred to the inguinal and vulval region. Pre-aortic nodes, para-aortic nodes. Clinical nodes before puberty, ovary is smooth and pink, grayish pink. After puberty, it is puckered and turns grey. When old, it may shrivel. Now, ovarian cysts, ovarian carcinomas, prolapse of the ovaries into rectouterine pouch. See, this is small 3 to 1 centimeter. You are having huge left-sided ovarian cyst. Huge, huge. And a lady will come, aged lady, the prolapse like this. We just open, see, examine, and this is the prolapse of the uterus. Now, this is the prolapse of the uterus, clitoris, bladder, and cervix, and a polyp. Young lady. Now, see, this polyp is one thing. You have to relieve her, you have to give some treatment. In those days, we could not wait for imaging, there was no imaging as such. On clinical condition, you will get many cases, okay? Now, cervical polyp, this is the cervix, this is the polyp. Now, huge uterine fibroid, this is huge uterine fibroids. I had operated on it. Now, huge ovarian cyst. Huge ovarian cyst. This is the fibroid. Ovarian cyst plus fibroid. Both nikal diya. Okay. Now, this is your no imaging, no CT scan, no ultrasound available on clinical aspect. We did a exploratory laparotomy. Like you are going to Antarctic expedition, going to Mount Everest expedition. Exploratory. You have to go and see and explore what is the pathology. It can be any surgery. So, this is ovarian carcinoma. This is the ovary and this is the uterus. See, this is the uterus. Now, see, this is the hydrosalpinx. This is the fallopian tube. Some obstruction is there, but the mucus and everything goes on secreted. So that swells up and pain is there. Naturally, this is known as hydrosalpinx. It can be, if it is infected, it is your pyosalpinx. Okay. Now the previous picture I showed you, the huge ovarian cyst with uterine fibroid. This cyst removed and the uterus removed. Now this is interesting. I came across a case. The patient, the uterus is not matured, did not grow. Now you see, this is one fallopian tube. Now, actually, when the development, organogenesis, during organogenesis, what happens? Two tubes come out. Sits on the vagina. I'm just telling you, embryology will be taken, but I'm just telling you, the two tubes comes in like this, and this is the vagina. And then with development and your things, this. The normal uterus develops. But in this stage, this is not developed. So you can I show you. This is the fallopian tube of the right side, and this is the left side. These are the two ovaries. Patient comes with no menstruation, then she's not having menstruation. And do a vaginal examination and saw that I could not feel the uterus. Then I suggested that you have to go for a laparoscopic. And I found this. Now see, uterus from single Mullerian duct. This single. Among this, it only there was no ultrasound, but full-grown baby with stethoscope. We heard the fetal ultrasound, a fetal heartbeat, and she came with dribbling of like with labor pain. Then we did a emergency cesarean section. Now, see, this OT sister, she was unprepared. So there was no gloves and all. I said, you just hold it. I'll take a photograph. When I used to do operations, when I used to suspect that this might be the outcome, then I had a small table with camera and gloves. This is not, the digital cameras are not there. There was no phone, nothing. It was a SLR camera. I quickly told her to hold it, and then I changed my gloves and took shot, and then I wore the gloves again, continued the operation. Few minutes, few seconds it took. But this documentation I have been doing for the 1975 till today. Till today, I clicked a picture of a wound. But nowadays, when we have the ultrasound or this thing, I have a guy. Even I have my whole photography set, everything. But I book him to do your video or still photograph professionally.